You know, in pediatric medicine, there are very few things as time critical as diabetic ketoacidosis, or DKA. If you get that first hour wrong, the consequences can be, well, they can be severe. So, in this explainer, we're going to walk you through the 2021 BSPED guidelines, focusing on the exact steps you need to take in that crucial initial window.
Let's just start with the single most important sentence from the entire guideline. This isn't just some theoretical exercise. The stakes are as high as they possibly get. Every single calculation and every decision we're about to talk about is built around this one fundamental, terrifying truth. So here's our game plan. We'll start by understanding why DKA is such an emergency. Then we'll dive into diagnosis. After that, we'll cover the immediate response, then the real core of the protocol, that all-important fluid calculation, and finally, we'll talk about why monitoring is so key. First things first, let's be absolutely clear what we're dealing with here. DKA is not just about high blood sugar. It's a full-blown metabolic crisis. The real danger actually comes from the body's desperate and ultimately toxic response to having zero insulin available. The guideline really zeroes in on 4 huge risks. The one everyone fears most is cerebral edema, brain swelling, which can be fatal. But look at the second one, hypokalemia, or critically low potassium. See how it's listed as preventable? That's so important. It tells you that following this protocol isn't just a suggestion, it is a direct way to prevent specific life-threatening dangers.
Okay, so a child arrives in the emergency department. Our first job is basically detective work. We have to confirm that it's DKA, and just as important, we have to classify exactly how severe it is. And that classification, it's going to dictate everything we do next.
You know, the diagnosis itself is actually pretty straightforward. It just comes down to 2 hard numbers. First, acidosis. That means the blood is too acidic, with a pH below 7.3. And second, ketonemia, meaning the blood ketones are over 3.0. If you've got both of those, you have your diagnosis. Simple as that.
So the second you confirm DKA, the very next question you have to ask is this one, because not all DKA is created equal, and the severity level is the key that unlocks the entire treatment algorithm. And the answer? It all comes down to one number, the venous pH. As you can see here, if the pH is somewhere between 7.1 and 7.29, we call it mild or moderate DKA, and we work off an assumed 5% fluid deficit. But if that pH drops below 7.1, we're in severe territory, and we immediately double our assumed dehydration to 10%. That single distinction, right there, is the foundation for every fluid calculation that's about to follow. All right, let's get into the action phase. The patient is diagnosed, we know the severity. What do we do in those first few minutes? It's all about stabilizing them and getting ready for the real treatment. And like any emergency, you start with the basics, the ABCs. Is the airway patent? Good. Support their breathing with 100% oxygen. And then circulation. This is the big one. Get that IV access. This is our lifeline for everything. Blood draws, and most importantly, starting those fluids. Now we hit a critical fork in the road. Is the patient in shock or not? The initial fluid bolus, 10 mils per kilo, it looks the same on paper, but how we account for it is completely different. For a shocked patient, that bolus is pure resuscitation. It's extra fluid and it does not count towards replacing their deficit. But for a non-shocked patient, that bolus is the very start of their rehydration and it absolutely must be subtracted from your total. Getting this one accounting step wrong can throw off your entire 48-hour plan. It's that important. Okay, this is it, the heart of the guideline. I know it can look a little complex, but I promise we're going to break it down step by step. This calculation is what determines the precise rate of fluid rehydration for the next 48 hours. And the logic is actually really simple when you think about it. The total fluid they need, their requirement, is just what they've lost, the deficit, plus what their body needs just to function normally, which is their maintenance fluid. So we just calculate those 2 parts and add them together. To make this super clear, let's use the example right from the guidelines. So we've got a 20-kilo child, their pH is 7.15. Now, as we saw in our table, that puts them squarely in the moderate DKA category. And for our example, this child is not in shock. Step 1 is the deficit. Since our patient has moderate DKA, we assume they're 5% dehydrated. So we just calculate 5% of their body weight.
A 20-kilo child is 20,000 grams, and 5% of that is 1,000 grams, which is equal to a total fluid deficit of 1,000 milliliters. Now we have to adjust for that initial fluid bolus. Remember, our patient was not in shock, so we have to subtract it from the deficit. They got 10 mils per kilo, which for a 20-kilo kid is 200 mils. So we take our 1,000 mil deficit, subtract that 200, and that leaves us with 800 milliliters that we still need to replace. Next up, their daily maintenance fluid. We use the standard pediatric formula here. It's 100 mils per kilo for their first 10 kilos, so that's 1,000 mils. Then it's 50 mils per kilo for the next 10 kilos, which is another 500 mils. Add them together and you get a total daily maintenance of 1,500 milliliters. And now, the final step, we put it all together. We take that remaining deficit, the 800 mils, and we spread it out over 48 hours. That gives us about 17 mils an hour for the deficit. Then we take the daily maintenance, 1,500 mils, and divide that by 24 hours, which is about 62 mils an hour. Add those up, 17 plus 62, and we get our final IV fluid rate, 79 milliliters per hour. And this is how it all looks in the official guideline algorithm. It might seem a little overwhelming at first glance, but if you trace the path, you'll see every single decision point we just talked about, from assessing for shock to calculating the fluids, all the way to ongoing management. It really is the entire process right there on one page. So the fluids are running, but our job is far from over. I mean, that calculation is just the beginning. Now comes the phase of really intense monitoring to make sure the patient is responding the way they should, and to catch any complications before they become a catastrophe. And this is what that vigilance looks like in practice. Hourly neurochecks are absolutely non-negotiable. It's our best way to watch for cerebral edema. A new headache or a slowing heart rate, that's a major red flag that needs to be escalated immediately. And all the while, we're constantly checking labs and keeping a super strict fluid balance chart. And listen, this right here is one of the most critical rules in all of DKA management. As the blood sugar starts to fall, you might be tempted to stop the insulin. You can't. You'll add glucose to the IV fluid to prevent hypoglycemia, sure, but the insulin has to keep running. Why? Because the point of the insulin isn't just to lower the glucose. Its main job is to shut down the body's ketone production. If you stop it too soon, the patient will go right back into ketoacidosis. So, the BSPED guideline gives us this clear, precise, life-saving pathway. But applying it perfectly requires intense focus and accuracy, all under immense pressure, which kind of leads to a final question for you to think about. In a chaotic emergency department, with everything going on, what do you think is the single biggest human factor that could derail this perfect protocol?